Yeah. So we'll have the dinner here only because of we know the NMC regulations, and unfortunately we had a sponsored dinner today at some place, but it was cancelled by that MNC due to NMC's new regulation. But we are really fortunate that this institute, they are providing us the dinner. So it will be from 7 p.m. onwards, the dinner will be served here. So I request all of you to stay with us for the dinner here only. So we are moving towards the next session, and that is on pediatric clinical pharmacology. And we are really privileged to have with us today Professor Shailendra Handu, sir. So welcome, sir. Welcome, Professor Shailendra Handu, to chair the session. He is the head at the Department of Pharmacology at AIIMS Rishikesh. So welcome you, sir. And also we have with us Dr. Sabnam Ara Begum. She is also a clinical pharmacologist and pediatrician too. So welcome, madam. So madam is now the associate professor at Arkapal Medical College. So over to Professor Shailendra Handu, sir, and Dr. Sabnam Ara Begum.
Over the mic to Sir Handu, sir, Professor Handu, sir, to introduce our speaker.
Thank you, Dr. Sabnam, and thank you, Dr. Shambhu, for inviting me and giving me this opportunity. I am really happy to join you all. I would have been happier if I could have made it to the conference, but that was not possible due to prior commitments. So I'm so happy to be with you and joining you for this session, which is on pediatric clinical pharmacology, which is an area of immense interest for clinical pharmacologists, both for reasons of conducting clinical trials in pediatric population and also the special needs of children as far as prescribing is concerned. So I'm sure that this would be an interesting session. I'm also delighted because I am joining in this session my dear Puneet, who will be presenting, and also 3 budding clinical pharmacologists from our association. So I request Dr. Sabnam to initiate the session.
Thank you,
so
sir.
Back to Dr. Sabnam.
Thank you, sir. Our first lectures on Nuances of Pediatric Clinical Trial by Professor Dr. Puneet Dhameja. He is professor at AIIMS Rishikesh, and he has done his MD and DN Clinical Pharmacology. Over to you, sir. Online. He is presenting online.
Yes. Thank you, the organizers, for giving me this opportunity to present this topic of nuances of clinical trials, clinical trials in pediatrics. Changing the sound. Can you see this slide? I have shared the screen. Yes. And is it visible, or do I need to do any other modification?
Yes, it is visible, sir.
Yes. Okay. Thank you, ma'am. Now, this topic of pediatric clinical trials is interesting in terms of because it involves lots of clinical, like you had said in your opening note, that the pediatric population is not the same as adults. They are not small adults, but they are actually individual entities which have their own pharmacokinetic, pharmacodynamic differences, and including pharmacogenetic differences itself. So what we need to do is we need to understand why we need to do clinical trials separately in pediatric population, And in the next few minutes, I am going to discuss about the challenges which are faced when we plan any studies in pediatric population. So I have divided my presentation in three aspects, three broad areas. The challenges which are scientific in nature, the challenges which we see are which are ethical in from the ethics point of view, and the third is from the regulatory challenges, the challenges which are posed by the regulatory body, or the challenges which are seen by regulatory bodies for promoting clinical trials in pediatric population. Now, moving on to the first slide. If we look at the WHO report, the most recent report of 2019, the burden of disease in the population in the world. Now, if we look at the top 10 global causes of death in 2019, lower respiratory tract infection, neonatal conditions, and diarrheal diseases were the most common causes of death. And all these three causes are usually seen in pediatric population, although lower respiratory tract infection definitely they can be seen in adult population also. And then if we look at the global causes of disability adjusted life years, they are again what we see is that pediatric population is again the more common reasons, which include neonatal condition, lower respiratory tract infection, diarrheal disease, and congenital anomalies. Now, these are the most common reasons for disability in the population. Now, if we upmost reasons for either the death or the disability for which the medical therapeutics need to find answers. But if you look at the number of clinical trials done for all these diseases, we see that hardly, if we compare the number of clinical trials done in adult population, in pediatric clinical trials are less than 10% of the adult clinical trials, total clinical trials which are done in adult population. So that is why we need clinical evidence which is specifically required in pediatric population, because there are many diseases which affect specifically only the pediatric population. The drug use in pediatric population can have long-term consequences in terms of physiological and the psychological outcomes which are seen in later in the development phase. Then another major area why we need to do some clinical trials or the evidence, generate evidence in pediatric population, because there is a development of age-appropriate formulations which are being developed for pediatric population, and these formulations need to be tested and tried in pediatric population only. Then definitely we all know that there are physiological differences in pediatric population which affect the pharmacokinetics, and then drug use can lead to specific ADRs in pediatric population. So we require a different types of studies which cannot be short term, which have to be long term to detect some specific ADRs which can affect the growth and types of the studies, the design of the studies, and the conduct of the studies are specific for pediatric population. Now, what are the scientific challenges and what can be the possible solutions for these problems? The first issue which is faced in pediatric population, like we have seen that there are a good number of congenital diseases which lead to disability. Now, congenital diseases are rare. So, if there is a low incidence of disease, we may not find the adequate sample size. Finding adequate sample size becomes difficult for generating generating convincing results. Now, what are the possible solutions for conducting clinical trials if the disease incidence is low? The first solution is develop use of registry and use of longitudinal studies. Now, this is one of the areas which has been exploited significantly by the pharmaceutical industry, but not much by the academics. Then the other way of conducting studies in rare diseases is use of modified endpoints, not conventional endpoints. Now, these endpoints could be biomarker based, could be patient reported outcomes, or could be time to event endpoints. But yes, these such endpoints will require time to event endpoints. They will require long-term studies, which may not be favored by the by pharmaceutical industry. But yes, biomarker based, if it is validated, they can be used as a substitute for hard clinical endpoints. Then the choice of control group. Because if the disease incidence itself is low, what all control groups can be used? Because in many countries, and I've come across a couple of regulations where they promote use of external or historical controls, especially when studies are being required to be done in pediatric population. So this is one of the solutions, use of external or historical controls. Then the second, another solution for conduct of clinical trials in low incidence with rare diseases, multicentric approach. We all know that it can help. And then there could be novel trial designs like N of 1 studies, which definitely N of 1 trials require the same approval process, same protocol writing, and it involves the similar kind of testing. Then the latest development as far as conducting studies in low incidence is the data sharing across clinical trials. Now, FDA and European regulations both are promoting the data sharing across the trials when the incidence of disease is low. Now, this could be one of the solutions which we can see in future. Then another critical issue specifically for pediatric population is pediatric dosing. Now, the most important issue is what is the right dose for pediatric population if we want to do a phase 2 study. Usually, what is given in the regulations is that 80% of the adult phase 2 dose can be used, which is rule-based dosing. But currently, with the availability of calculus, all the technologies, or the modeling, continual reassessment method models are being used, which is basically adaptive dosing models, which are being promoted by regulatory bodies, which can be used. And a number of studies have been done recently, which are using this kind of adaptive dosing models for identification of the right safe pediatric dose. Then another thing which we all know is all about the pharmacokinetic guided dosing. Now, how pharmacokinetic dosing, kinetic guided dosing differs from continual reassessment method is in continual reassessment method model, it is the pharmacodynamic parameters are also considered. While when we talk about pharmacokinetic guided dosing, it is only the pharmacokinetics which are considered for identifying the safe dose, pediatric dose. Then whether we should be relying only on the dense kinetic modeling or sparse sampling method. Now, sparse sampling, because in pediatric population, the amount of blood drawn could be an issue. The frequency of pricks and all those things could be issue. It is not the same like for adults. So, sparse sampling based dosing, pharmacokinetic dosing is also being promoted. Then utilization of adult pharmacokinetic data, yes, that is there. And then another recent development is the use of simulation and modeling. Now, for identification of the dose. Now, whether regulatory bodies are open for accepting the data from simulations or the PKPD modeling, which are basically based on mathematics and calculations. So now that is evolving, and we should see the use of simulations and modeling as one of the solutions for pediatric dose, identifying the right dose. Then use of pediatric appropriate formulation. Now, this is again going to be a chicken and egg story, whether we need to develop the formulation first and test the formulation, or we need to identify the safe starting dose. So this is another area which requires specific deliberation. The use of specific pediatric appropriate formulations is another challenge for which probably we can see some kind of solutions in future. Then another scientific challenge, or we can club it as an ethical issue also in pediatric clinical trials, is use of placebo. Now, everybody understands, because being a parent, everybody understands that if somebody tells us that our child may get the active treatment or may get a placebo, it is going to create a lot of apprehensions. So what is required is informed decision making prospectively. So new innovative and methods are being designed in seeking the informed consent from the parents whenever it is a placebo controlled trial. So informed consent decision conventionally are taken on the basis of the meetings, and those meetings, especially in pediatric age group, may take can be a series of meetings rather than one time or two time meetings which will give us the results, which will after which the parents can give the consent. Then another solution to use of placebo in pediatric clinical trials is, if the protocol mentions providing effective treatment at the end of the trial if it is proven to be effective. And use of interim analysis, definitely we will not get into the statistical details because of lack of time. So providing effective treatment at the end of the trial is going to give some confidence to the parent that at least the child is going to be treated. This is one of the way by which we can convince the parent about use of placebo. Then another solution to this problem lies in the use of Zelen randomization technique, which is practically seeking the consent if the patient or the subject or the participant gets into the placebo arm rather than getting it into the active control arm. So this is use of Zelen randomization is documented in the current recent literature. These are the solutions, possible solutions, but yes, there are other issues also as far as pediatric clinical trials are concerned. Then the other issue is the sample collection. In pediatric population and the blood volume. Sample collection required that in pediatrics there should be a reduced frequency of sample collection, the reduced amount of samples which should be less than 3% of the total circulating volume, which is not, while for adults it is less than 5% of the circulating volume. Then alternative sampling techniques like finger or heel pricks, and this requires the development of special analytical methods also, which can be used in pediatric clinical trials. And if we want to avoid the use of sample collection, use of pragmatic trials or design is one of the one of the key solutions which can be used for this problem, where the sample collection will required will be less. Then what outcome measures are required for developing a drug, for approving a drug for in pediatric populations? One critical issue is that if we have a subjective outcome, it becomes difficult to assess because the child may not be able to tell us about the severity of headache, nausea, vomiting. The use of subjective outcomes is difficult to assess. So what could be the solution is this use of scales or FACES scales which can be used in this situation. Then use of age appropriate tools, like for neonates, because pediatric population is from neonates to adolescents, where the growth and maturity level changes. The use of age appropriate tools in a particular specific age group and as outcome measure can be one of the solutions. Now, there could be studies where heterogeneous age groups are required. Like I discussed in the beginning that some studies will require long-term analysis. And over a period of time, the pediatric population or the participant evolves in the development from neonate or from infant to maybe a toddler to that. So, use of age-appropriate specific tools is required. Then can we use proxy responses from family members? Now, this is one of the solutions provided the clinical situation or the problem can be answered by the responses, the solution could be found by family members. So, use of proxy responses can also be used as can be one of the solutions for outcome measures. Now, what are the ethical challenges? The most important ethical challenges comes in the form of informed consent, where we seek proxy consent by the parents or the guardian. Now, in this situation, although assent has been documented and that assent should be taken from the participant, but if we look at the actual scenario, whether the child or whether the consent should be taken from both the parents or from the single parent, assent should be taken from the child. If the child is not ready, if the child is not convinced, after one session of interaction with the physician or the investigator, how many sessions should be devoted for that? So these are the actual ethical challenges. Then emotions, understanding and experiences. Again, these differ between adults and a child. So there could not be any major solution for in seeking informed consent, but except for the better interaction at the recruitment, then goodness of fit consent procedures according to using the age appropriate consent form and using the age appropriate method and the study and the procedures as per the study design and the study design. Then seeking assent from children. We cannot have major solutions for getting the informed consent from the which are innovative as far as informed consent is concerned. Then another challenge is, ethical challenge is payment for participation. Whether the participant or the parent should be reimbursed only, or they should be compensated for any kind of injury, and how much should be the compensation. Then should there be an appreciation for participation, and should there be incentive for participation in the study or not? Now, regulatory bodies definitely discourage use of incentives for participation in trials. But for pediatric population, since we do not have the data, should this be promoted as well? Should incentives be promoted, and appreciation? How to appreciate the participation in clinical trials, in pediatric clinical trials? Because it is usually, we know that we need data, but until participation is encouraged, we will not get the result. Then another issue is safety monitoring and protocol reviews of pediatric clinical trials. Yes, in both the situations, it is required to have pediatricians who understand the child. And when we talk about the review or protocol review, laypersons with experience in pediatric rights and well-being should be encouraged, should be invited. So there are some modifications. These are just brief modifications about the safety monitoring and the protocol reviews, and specifically for pediatric clinical trials. Now, what could be the future directions in terms of, we have seen the challenges which are there in scientific areas, we have seen some challenges which are in the ethics, field of ethics, and what could be the solutions? Now, clinical trials have got many scientific and ethical issues. More regulatory initiatives are required for promotion of pediatric clinical research with focus on specifically pediatric dosing studies, with innovative designs and with innovative methodologies. One major area where the solution lies is accepting data from simulations and modeling, using adaptive trial design and adaptation. This is coming up like anything, and we are moving from using Bayesian, using frequentist statistics to Bayesian statistical models. Then promoting use of technological advances, which could be digital in nature, and use of devices, and the feedback form which are friendly, which are child friendly. Most of the child are now moved to, they use better, they are better at using smartphones than the adult population. And continual re-education of researchers and reviewers is required. Like in the previous session, we discussed that, it was discussed that the subject expert committees and the ethics committees, especially for biological use of biological, they need to be trained. And in the same way, researchers and reviewers need to be trained for analyzing and assessing the use of the clinical trials in pediatric population. So this is all that I have, I could present, but yes, there are many other issues which are there in pediatric clinical trials, which needs to be discussed. But this was just a snapshot of what we, briefly what we can see.
Thank you, sir. It is a very insightful and very enlightening sessions, and all the things are very meticulously highlighted. So, in short, you have said there are certain things, and what are our future directions. In main things you have mentioned, I think, are like ethical considerations and other thing also. Now I'm requesting our participants, if they have any, both online and offline, if they have any one or two questions to sir. Sir, I have one question. You have mentioned many things, but one thing is also important, the formulations. Formulation for pediatric age group, because for liquid suspensions and that kind of tablet should be disintegrated, orally disintegrated tablet, that is also a challenging thing. And also for ethical issues, if the clinical trials they are for prolonged period of time, then when their child their guardians are giving their consent, but after they are attaining 18 years and or they have given assent form, then they should be taken that informed consent form. That is also challenging, whether they will they will stay in that trial or not, and also long-term safety. That is also.
Yeah. Yes, ma'am. The first point that pediatric specific formulation.
Yes.
Now, when we were child, we never used to see such kind of formulation like which are strawberry flavored or banana flavored and all those things. Now we see even paracetamol it comes in multiple flavors. Now this is one area of development. Now what all, how much research and how much data should be generated for approving such formulations, and what is the regulatory requirement? That is one thing. Second thing is that if the drug is new, if and the drug development takes at least 4 to 5 years or of clinical development phase. During that clinical development phase, if the formulation changes, what should be the starting point? What all the data, how much data should be accepted by the regulatory authorities, and when the formulation changes, like the flavoring changes, now that is again an area which needs to be discussed.
Yes.
And yes, you very rightly said, as the child grows, his or her experiences and thought process change over a period of time. So if the child is an adolescent, he has given some kind of he has given assent. There is a provision of seeking reconsent. Yes, it is documented. And if the child was too young to give assent at the time of enrollment, assent has to be taken as soon as he attains the specific age.
Yes, sir.
Age of 7. So these are inbuilt. And but whether at the age of 7 years, child actually has got a mental
Yes.
ability to give assent or not,
It is dubious.
that needs to be assessed further.
Yes. That is the thing.
Right. Can I ask
Yes, sir.
Puneet a question, please? So Puneet, you spoke about incentives and you mentioned that this must be discussed, but you did not give your own views. I would like to hear your views on providing incentives for participation of children in clinical trials.
Sir, what I could come across the literature, what was published, is that it is a grey area actually. What it says that incentive should not be actually inducement for participation, because parents might enroll the patient subject in the clinical trial just to get some inducement, which may not be right. So the quantum of incentive that has to be given should be approved by ethics committee from a time to time, it should be on the basis of pro rata basis, how much for how long the child is participating in the study. But if without incentive, if giving the incentive, again I would say that it will improve enrollment into the studies, and we will be able to generate the data which is required for scientific decision making.
Okay.
Until participation is yes, sir.
Yeah, thanks for those inputs. I do think that, you know, in a country like India, where a lot of our patients that come to, especially government hospitals, they are in a socio-economic category where even small incentives might be an inducement. And when the thing is not happening to you yourself, it's a child, and we've heard of stories about, you know, children being all kinds of things can happen with children because it's not happening to you personally. The pain is not happening to you, and sometimes, you know, parents may not even understand the degree of hardship that a child might go through. So in my mind, if somebody was to ask me, I would say, you know, we should be distancing ourselves from incentives for child participation in a clinical trial. How desperate are we? How many products are there that are only for children? If we don't give incentives for adults, then why should we be giving incentives for children? That is my thought process. But as you rightly pointed out, this does require a lot of discussion, I suppose, and there would be other points of view, and it would be good to know those. Thanks. Thanks, Puneet.
So maybe, sir, I just taking you, sir. Maybe like let's say we have a rare disorder, and we are enrolling patients from registries. So the patient or the participant or the parent may not be willing to come again and again to our center because ours is a tertiary care center, maybe where this trial is going on. So in those situations, maybe incentives could be justified basically because since the disorder is rare and it has to be decided on a case-to-case basis. We cannot have a blanket statement for that.
Absolutely.
This is what I feel, sir.
I agree with you. So depending on the rarity of the disease and how difficult it is to get patients for that, and therefore certainly reimbursement of travel and things like that are absolutely necessary. Maybe we should go beyond that to think of if a parent is accompanying the child, then the loss of wages for the parent, and that needs to be reimbursed as well, which we normally don't do for other kinds of trials. And to some extent we might go beyond that as well. Agreed.
Thank you, sir. It's an excellent discussions with you, and your presentation is very good. May I now, without any delay, I switch over to our next speaker, Dr. Arkapal. He has done MD and DN Clinical Pharmacology, and he is an assistant professor at AIIMS Kollani. And his topic of discussion is clinical pharmacological considerations and challenges in pediatric prescribing.
I really thank the organizing team for giving me this opportunity, and after 2 days of intensive clinical pharmacology related discussions, I think my topic, the way I have prepared it, is mostly focused to postgraduate residents per se. So my topic for today is clinical pharmacology considerations in pediatric prescribing, and it's great to present after Puneet sir and Handu sir being one of the chairpersons. They are my mentors from my DM, and some of my faculty like Dhameja sir, Tripathi sir, with whom I have worked for a long span of time of my infancy career. So I have recently joined AIIMS Kalyani as an assistant professor. So I am a very newbie in the faculty life, and this is my first talk after becoming a faculty. So I'll start. So one of the residents here was I was talking to him, and he was saying that the topics which we have are very advanced in our conference are very advanced, and those kind of things will not come in their PG exam questions. So I can assure you that the most of the discussion which I'll be doing will be based on the basic pharmacokinetics and dynamics, and we'll try to correlate with all the clinical research aspects also. So firstly, this is my brief agenda, and we'll be focusing on certain very basic kinetic parameters, and then the importance of irrational prescribing in pediatric population, and lastly we'll conclude our talk with certain tools for rational prescribing which were developed in the past. So recent mishappenings have been a point of concern for all of us, and this is one of the very recent ones. Like as of first week of August, this report was presented in one of the newspapers. Like WHO has issued a caution against Indian cough syrup, and this time it is in Uzbekistan and not in some African country like the previous ones. So these have become very common, and the coming to an ideal medicine for our children. So WHO states that any medicine which suits the age and physiologic conditions and body weight, and it is easily delivered to a child, should be considered as an ideal medicine. And now coming to all the pharmacokinetic and dynamic parameters, as we know that pediatric population, pediatric age group or the pediatric body per se is very significantly different from an adult body, and there are various kind of physiological changes which incur with passage of time from a neonate to an infant and to a children to adolescent. So these kind of changes are very, very important in understanding the functioning of a drug in the body, and so the kinetic parameters are altered as well as the dynamic parameters, specifically the number of receptors, their activities, the affinity of the receptors. are highly variable. So these changes with disease severity, with comorbidities, various age-related factors also. So now coming to certain, we'll just rush through some of the points with consideration to absorption, the pharmacokinetic parameters like liberation of a drug from a formulation. It can significantly differ the gut transit time and the intestinal fluid composition also, and these can affect the drug dissociation. A very simple, intestinal transit times are very higher. These are shorter in younger children, which may reduce the amount of drug transport, as the drug will be very fastly moving through the intestines, as well as there is change in the gastric pH. And the gastric pH in the newborn is very alkaline, where over time it becomes acidic, and bile secretion is also altered in the first 2 to 3 weeks of life. It is known to be poor with luminal concentration, which is much lower than that of the adults. And the intestinal permeability is also very different. So these affects the absorption and distribution of the lipophilic drugs as well as the hydrophilic drugs in the body, and large volume of distribution in infants is seen with lipophilic drugs as compared to older children. Now coming to a very important factor like drug distribution, what happens is, if you see in the neonates, there is reduced number, the reduced concentration of total proteins, plasma, albumin, globulin. Apart from unconjugated bilirubin and free fatty acids, all the plasma proteins are reduced, and over time the gradual normal levels are attained in the and as soon as as soon as the age increases, all these convert into adult concentrations. So now some points pertaining to metabolism of the drug. So microsomal protein content in the liver increases with age, and this is very, very important for metabolism of the drug. And we can see from this image, and this has a very significant impact on pharmacogenetic considerations. As we can see, if you see, the blue line is basically normal metabolizers, normal metabolizing protein expression. It increases as the child grows from neonate to infant to child to a child, then preteen, and it attains adult level, whereas the poor metabolizers remain low. So the difference in concentration of the drug in a neonate is very similar to each other, whereas there is a difference as soon as the age increases. Now, if you see the elimination perspectives, the GFR gradually increases, and it from the neonate perspective, it increases, almost doubles within 1 week and reaches adult value by the end of first year of life. So these are certain. So to summarize, all these parameters significantly influence the effect or the absorption, distribution, metabolism, and excretion of a drug, and basically alters the effect. So now a formulation, because we have discussed so many events have occurred, formulations play a very, very important role, specifically the taste, odor. As sir was saying, there are different types of preparations, various flavoring agents are being used. The excipients have become the talk of town because of the severe impurities which are affecting, which are causing these adverse reactions. Then dosing frequency and product stability has been a lot of concern. So I found this guideline, the STEP database, that is safety and toxicity of excipients, specifically for pediatric age group, is a STEP. It is a database which aims to improve availability and access to public, published information pertaining to excipients, and these develop a platform for systematic assessment of excipients. So this database is present, which can be used as a guideline for the industries for a quality control of these kind of formulations. Now, what are the challenges in pediatric medicine pertaining to pediatric prescribing? If you see, the developmental changes impact the pharmacokinetics of the drug in a child. Pharmacodynamic activities are also influenced. If you see taking an example, suppose a GABA receptor are very limited during the early period of life in the neonates and infancy, and gradually over a time, of the first 3 to 5 years, they attain normal levels. So GABA agonist cannot be used in the early period of the child's life. So children receive a very big problem in our situation, especially in a resource deficient country, is the children are receiving medications from different settings. So some children can go directly to a general practitioner, some go to a unorganized sector, some go to quacks, some the fortunate ones can go to trained pediatricians or a specialist hospitals. So the number of medications which they are exposed to are extremely high, and the experience of the prescriber is also of a varied level. Some of them are exposed to experienced pediatricians, which the fortunate ones are actually exposed to experienced pediatricians. So their expertise are also variable. So what are the challenges in pediatric prescribing practices? So prescribing appropriate medicine of appropriate dose duration is very, very important. And another very important point is overzealous use of antimicrobials. Because these days viral flu are very common, and the treating physicians often prescribe a antimicrobial drug which is obviously not always necessary. So overzeal of antimicrobial use for prolonged period of time can lead to a lot of unwanted side effects. Then designing better pediatric formulations, as sir was discussing in the previous presentation, lot of improvements have been made in the recent past which was not present before. So, and minimizing drug administration errors is very, very important, and obviously minimizing unwanted exposure will lead to reduction in adverse effects. And improving drug compliance. Since our country is a developing country, there is not much regulation, the people are not well literate. So improving compliance, the counseling of the patient is as important as delivering the right medications, so that the patient or the caregiver is trained on how to use the drug and how to avoid misuse. Then again, rampant self-medication practices is also very, very common in our country, as the caregivers, the parents are always itching to, give the children treatment for any minor symptoms which are not always necessary. Now, drug evaluation, if you see pediatric drug evaluation, evidences are generated from various sources, and evidence from adequate and well-controlled investigations, specific to pediatric indications, are different from indications approved from adults. So if you see the first point, so this is like developing a new drug through a whole chain of drug development process to approve a drug which is different from pediatric indication, and it will incur a lot of cost. But commonly what is done is the evidence is generated from pediatric population to support the same indication approved for the adults. And studies in adult populations have additional information in specific pediatric population. So basically you conduct a trial in the adults and you extrapolate those data to pediatric population. We conduct a trial in adults and we do some add-on studies in pediatric population just to validate the use in pediatric population. So the second and the third point are most commonly performed in routine practice, while the first one seems to be ideal, but it is always not feasible, and it is extremely expensive, as well as is not always ethical, as sir pointed out earlier. So now coming to rationale of extrapolating approaches, if you see the EMA and FDA approaches, the adult data, whatever data we have from an adult use of drug in adults, these data are reduced by drug based on scientific rationale, and these data are extrapolated by using PK/PD studies, using PK/PD modeling, and using simulations. So these data are extrapolated to pediatric population. Similarly, FDA has also followed a similar approach where the adult data is modified according to the disease and responses to treatment and exposure response relationships. are very, very similar, and these are actually integrated into PKPD models to infer a different dose for pediatric population. So the similar is shown in this table, where validation and extrapolation in pediatric subpopulation are basically categorized based on the data which is available in adults. And these validation methods, the usual ones are the modeling approaches, the simulation approaches, and the PKPD studies which are done, and hence the data from adult is extrapolated to the children to accurately predict, to approximately predict the dose which can be effective in children. Now the challenges in pediatric research is not limited to only the dose finding. There is limited data on efficacy and safety also, as well as the unfamiliarity with age-related developmental pharmacology in pediatric group. And obviously there is ethical consideration with conducting a pediatric research, as sir had earlier pointed. So this paves the way for off-label use of drugs in this age group. And we have seen the term therapeutic orphans. The children are often they are pointed out as therapeutic orphans because there are no specific trials or research directly on the children, and there were unavailability of pediatric oral formulations. But nowadays there are a lot of preparations which are coming up, and there is obviously, our country being a developed country, unequal availability of drug across different countries is also an issue. And interesting use is unlicensed use among this age group. Use of unlicensed drug is very high. Then what are the challenges in off-label? If you see the point I want to highlight, in primary healthcare settings, the incidence of off-label prescription in India has ranged from around 30 to 50%, whereas the prevalence can be as high as 90%. So this is the extent of which the off-label prescription is practiced in India, and this is a concern. And the pediatric dosage regimen are usually linearly extrapolated from adult dosage regimen, which is not often the correct approach which should be followed. This leads to obviously inappropriate dosing. It can be overdosing or underdosing, since the developmental changes in the pediatric age group is not always linear. Now lastly coming to some of the rational prescribing tools. These tools are, I have taken these tools from a systematic review on prescribing tools in pediatric population. These are mostly focused on Western data, but I wanted to highlight this. So there are POPI scores and modified POPI score. So POPI stands for Pediatric Omission of Prescriptions and Inappropriate Prescription Tool. And there is another tool which is known as Indicator of Potentially Inappropriate Prescribing in Children. So the first tool developed was the POPI one, which had 125 criteria. From that it was downscaled to a modified POPI tool where around 80 criteria were present. And the 2019 PIPC tool had around 25 criteria. So these criteria were given according to the disease per se. They were developed by expert group by a Delphi's consensus in unspecified healthcare settings, where the specific focus was on rationality of pediatric prescription. And they had pointed out the correct drug dosage, duration, drug interactions, then over prescription, under prescription, and based on that a scale was developed. But there was no focus on food drug interaction. So these were mostly developed based on Western databases. So lastly, obviously we have to do risk benefit analysis of off-label use specifically and these kind of vulnerable population. And a clinical pharmacology presentation is not complete without a safety, a slide on safety parameters in pediatric prescribing, especially where multiple medications are very commonly used. So adverse drug reactions are one of the most commonly underreported. It is even more important because off-label use of drug is high, and inappropriate and irrational drug usage is also on a rise. So summary to conclude, pediatric dosing is a very complex interplay of physiological and anatomical changes, and optimized therapy is need of the hour, and polypharmacy, especially in our settings, has to be reduced. And as Madam had introduced, every child are not mini adults as considered in many cases. So that's all. Thank you very much for the patient listening. And before I conclude, that we had an extensive discussion yesterday regarding the clinical pharmacology services and all the services which can be delivered. So our institute is a very new institute. So I am attached for the last 7 months. So it's a 3.5-year-old institute, and we are happy to say that we have started TDM services in collaboration with biochemistry department. So they are doing the analysis and we are reporting. They are doing the assays and we are reporting and doing the clinical modification. We have started for 2 drugs as for now, lithium and valproate, and pharmacovigilance and other services have also started, and we are planning to open the clinical pharmacology OPD. So hopefully the things will run in a good path. And my mentors are here, Professor Handu sir and Puneet sir, my mentors from my DM days. So in AIMS Rishikesh also we were fortunate to get funding from central government, and there is a full functioning clinical trial unit set up where around 8 to 10 people are working. There are CRAs, trial project managers and data entry operators associated with the clinical trials, and as of now around 5 to 6 trials are underway in collaboration with oncology, hematology. So it's although there is a lot of scope ahead. So these are some of the points I wanted to share. Thanks a lot for patient hearing.
Thank you.
Sir? Ramji sir is here. Yes, sir.
Thank you. It is an excellent presentation. May I now request Professor Shailendra Handu sir to say something? Sir? Sir, please unmute yourself.
Good evening, sir.
Yeah. Okay. I think it's a moment of pride for me that our dear student Dr. Arkapal is presenting, and so I'm so happy. And I think you can carry on with the discussion. I think it was an excellent presentation by Dr. Arkapal, and he highlighted most of the areas of challenge while prescribing in pediatric population. So, if there are any questions from the audience, both offline and online.
Yes, sir.
I think back to Dr. Sabnam.
Yes, sir. Sir had some Sir had a comment. Bhaskar sir.
Comment. Not a question, but a couple of points. One thing which I think we generally tend to forget is that when we talk about pediatrics, whether it comes to clinical trials or whether it comes to prescribing, we are actually not dealing with a single population. We are dealing with many subpopulations. Because within pediatrics also, we have preterm infants, we have neonates, we have infants, we have say children in the 5 to 7, 7 to 12 age groups. So it itself is a heterogeneous population which further makes it more complex. Because any study which is done in say neonates is not applicable, or rather the generalization would be to such specific population. And second thing is just a suggestion from my side. Of course, we are very early in the stage of the society, but can we come up with a statement or say recommendations for pediatric clinical trials or guidelines or for prescribing or something like that? Maybe later on, once things we get rolled out. That was all.
Society has to be registered.
Yes, of course.
You have to do that.
Of course. Thank you, sir.
No, this is because you told 3.5 years is AIMS Kalyan started, huh?
Yes, sir.
Yeah, because I went there, I think, 2 years ago to take MBBS students. That time it was 50 students. Now it is.
Yes, sir. Now it is hundreds.
100.
125, sir.
But you have good setup. And that boy who was alone that time.
Yes, sir.
Who is his name?
Kaushik, Dr. Kaushik, sir.
And now I think full team.
Yes, sir.
So you take a challenge. You start their separate unit of clinical pharmacology.
Yes, sir.
And do something so that your boss will be proud. We will also be proud. Okay?
Sure, sir.
Now, this is actually giving me an idea about, we have guidelines for adult clinical research, we have guidelines for pediatric clinical research. I was just wondering, there is another lecture we are waiting for, that is fetal pharmacology. So what about fetal clinical research, if you think of? There is no guideline really. That doesn't fall under pediatric. It's yet unborn. Okay? So just going through that maternal fetal medicine and obstetric research. There is a group. Fetal surgery clinical trials. This is Mayo Foundation. So we can try to understand this matter. Of course, we are going to hear Dr. Sumalya Sen, who has a lecture now. But then Dr. Arkapal, you can also think over that, put some thought into it.
Yes,
and then again, coming back, maybe nothing is there. So this association can think of developing some kind of a guideline or can put forward to ICMR. Whether ICMR can come up, maybe in 3-4 years' time, we can also think of having clinical trials or the interventions, medical interventions during the fetal stage. There are some areas where there is a need and people have also tried, and there are some interventions that are already in practice, although it might not be very common, but then there is an area. And besides clinical pharmacologists who can actually develop insight and put their advisory. I thought it is worthwhile to mention here. Thank you.
Thank you.
Perinatal clinical pharmacology. Yes, sir.
Thank you. It is a wonderful, wonderful and excellent presentations. May I now request Dr. Sumalya Sen. He has done MD from CMC Vellore and DM from School of Tropical Medicine, and he is my co-PDT. He is now attached to as an assistant professor in Godagiri Medical College, and his topic is, sir already mentioned, trains in fetal pharmacology. Let's hear from Dr. Sumalya. Godagiri Medical College. It is near Durgapur.
So it was a very nice session since morning, and the previous two discussions was very important, and it will be as a continuation. And I am very fortunate that there is no overlapping, because we speakers, we do not have any discussions earlier that we will made it like that way. But I am fortunate that there is no overlapping part from my side. So to start with the fetal pharmacology, the very important aspects will be the how to assess, and definitely the dosing, dosing in terms of not always the fetal therapy is required.
You can continue with your talk and then.
Okay. So the thing is that how the dosing, if at all required in some cases, how it has to be done, and specifically the designs for studies, how it has to be.
I'll look into it. You can.
আমারটা সে এখানে সাপোর্ট করছে না, আমার পেন ড্রাইভে আছে বাট সাপোর্ট করছে না সিস্টেম, আমি পেন ইয়েতে দিয়েছি। So the important thing is that the kinetic part and the extrapolation that we were discussing, that we were discussing for newborn. But definitely, if any dosing or anything we are planning for fetus, if at all we are planning, in that case there also should be some study. So here this PBPK is very important, that is the pregnancy physiology based pharmacokinetic model, and that one really helps in case of these fetal issues. We will discuss to some extent regarding those points. Is it uploaded? So as we all know the basic about the fetus, that the intrauterine life, the fetus always exposed to series of drugs and toxic substances that the mother is taking, and that effects can be immediate, that can lead to fetal death, that can be just after birth, or that can be delayed effects. So all these three possibilities will be there, and the correlation of this intrauterine exposure to the drug and pathological damage, that assessment is very difficult because we are unable to do the study upon that. But we can just do a association or assume that there may be an association between this drug exposure and the risk, and we know that from the history, a landmark drug that is the thalidomide, how that history is giving us, or that acts as an eye opener. The placenta is actually an organ which offers a safeguard environment to the fetus, and placenta do have lots of is it okay, sir? And the placenta actually protects us from protects the fetus from lots of hazards, definitely from the drug exposures and other issues. Now we know that this is from our medical school we understand and know about this fact that the simple diffusion mechanism and the active transport mechanism. The simple diffusion mechanism, here the majority of the drugs crosses the placenta, and concentration between this maternal and fetal circulation will be there, and basically it depends upon this physiochemical property, that is the lipid solubility, degree of ionization and the molecular weight. Mainly these three properties. And active transport, again we know that there should be certain method for this active transport process, and certain endogenous compounds like amino acids, creatinine, sodium, calcium, phosphate, they usually utilize this method. Now transport of some very important molecule like glucose, vitamins, micronutrients and iron, along with some other things like insulin. Right now I'm not going to discuss individually, but just highlighting point that the glucose usually by the facilitated diffusion, and vitamins again they do have their own mechanism of transport, micronutrients and iron again that too also have the same mechanism. And again, if the transport is not acting properly, in that case fetus will be devoid of that important vitamins, and there may be a developmental problem or a birth problem or a birth defect. That's why at the very beginning, from the commencement of the pregnancy, lots of important vitamins and important things that is given to the mother. Now insulin we know that it has been shown not to cross the placenta in significant amount in human being, but that is having a certain receptors, the IGF-1 and IGF-2 receptors, through which it causes the development. We know that there is this important two things, that the lipid solubility and the protein binding, which two actually regulate the placental transport. Regarding the lipid solubility, we know that this is due to the flow dependent that occurs in case of this maternal and the fetal circulation, and here the high permeability of the placenta to these drugs is actually reflected by the rapid transference. And sometimes in case of labor or during labor, when there is a contraction, in that case the flow is reduced, and that leads to decrease in the maternal-fetal circulation. Next is regarding the protein binding. We know that there is the maternal side plasma protein and the fetal side plasma protein. Both the sides, if the drug crosses the placenta, that will be binded to the maternal side. After that, after crossing, it will bind to the fetal side plasma protein, and there will be a time taking procedure. Now if the drug is a highly plasma protein bound to the mother, in that case the duration of action and the crossing the placenta, that safety issues will be there, and we have to think about that whenever we are prescribing a drug to a mother for terms of safety of the fetus. we know that this is again a very well-known picture from our pharmacology classes, that the absorption, distribution, metabolism and excretion model, and here in case of mother and fetus we can see in the left side and in the right side. In the left side the bound and unbound form, we know that the unbound will cross the placenta and go to the fetus side, and after going into the fetus side again that will be either bound form or it will be metabolized, and if it is metabolized it will be excreted into the amniotic fluid, and we know that in the fetus the amniotic fluid will be swallowed, and after that again there will be two possibilities. One maybe it will be in the fetal gut or it will be again unbound form or go to the tissues. So if we move one step ahead, we will see the PBPK model, that is the that is the pregnancy physiology based pharmacokinetic model. Here normally PBPK model, this last part is absent, that is the fetoplacental unit what we can see. But in pregnancy, this is one extra unit that we can see in PBPK model, that is the in the lowest part that is shown, that is the fetoplacental unit, and that fetoplacental unit is so the fetoplacental unit, that is a extra part if we do modeling for fetus and the dosing calculation for all those purposes. So here we can see that the from lungs, adipose tissue, bone, brain, all the tissues has been included, and here the fetoplacental unit, in the right side the arterial and in the left side the venous blood. Now we know just few basic points about the PBPK model is it will actually a predictor for the maternal and the fetal exposure of the drugs. So by integrating some important points like physiological data, preclinical data and clinical data. So these three are the key points that is fed into this PBPK model in pregnancy, and that can be used to predict the maternal and fetal exposure and guide the optimization of the maternal dosing during pregnancy when pharmacokinetic studies cannot be readily performed. Now we will come to that currently US FDA and other regulatory bodies also have given a nod, not only currently, long time ago, given a nod, and lots of drugs getting approval based upon this PBPK model. So validation of this model is a very challenging issue due to limited clinical data. So amongst these 3 points, the physiological data, preclinical and the clinical data. The clinical data, getting that clinical data is very crucial and that is very important, but that data is lacking to some extent, so the validation of these models is challenging. Now PBPK modeling can also serve as a tool to guide the drug dosing during the breastfeeding based on the drug transfer through the human milk. Based upon the same model, in the breastfeeding women also, they can have the similar simulation technique, and the maternal and the newborn exposure to the drug or the probability of exposure of the drug, if I say correctly, that can be assumed. So here we can see, though this is a little bit busy slide, in the left side we can see the ideal studies. In the middle part we can see the next best alternative, and in the right side we can see the alternate approaches. The ideal studies, it's like that, the drug exposure studies in first, second and third trimester and postpartum. But practically speaking, it's not always possible because of certain ethical issues in pregnant mothers doing studies. Next is the drug response studies over a dosing interval. We are looking into the left part right now. The drug response studies over a dosing interval, again that is very difficult conducting in pregnant women. Maternal drug safety also, those are the difficult areas to touch. So next best alternative what we have in our hand, it's like that surrogate drug exposure studies, some alternate marker we can utilize to have this our result. Next is limited drug response, so that the limited sampling strategy we can use. Placental perfusion, cord blood sampling, milk to plasma ratio we can utilize, but alternate approach that will be minimally invasive and ethically correct, that is in the right side, that is the prediction based on the probe drug studies on drug metabolism, excretion and transporters. Next is the population pharmacokinetic modeling, and third one is the PBPK modeling and simulations. So these are the alternative methods that we can use, which is actually we are overcoming the ideal studies, because conducting those ideal studies in pregnant mother and sometimes newborn and fetus is sometimes maybe ethically incorrect. This one is not visible, I am skipping this slide. So to some extent that has been covered by Dr. Orko in the previous presentation. Next, the current gap in the modeling in maternal and fetal pharmacology, it's the lack of data. In the maternal side, is the main problem is the lack of data and the enzyme during the pregnancy and the postpartum period, that one is lacking. Next is again the lack of data on time course changes on different transporters, that one is lacking. Lack of data from same person during and the post delivery. So majority of the cases it's from different persons. So from the same person, that one is lacking. Now like that way, lack of PBPA models of the biologics, that is also missing. Fetal pharmacology also, there are certain gaps like actual fetal exposure and blood or tissue concentration prediction is not available. Lack of data on exposure response relationship in fetus and sometimes maternal placental fetal drug partitioning. So earlier what it was done from the adult studies extrapolation, but now as the days and research is progressing, so what we are doing, we are actually making this model that is fitting the mother and the fetus, and after that we are feeding with the correct data of previous studies and we are simulating this for the present situation for that particular fetus or the mother. This is another way, that is the probe drug based studies. Probe drug is actually a drug that is utilized for having or knowing the pharmacokinetic properties. It's like enzyme or transporter activity determined using this probe drug data, which is specific to the trimester. So say for example, if the probe drug study has been done for third trimester, we cannot utilize it for first trimester. That will be only for third trimester and only for that drug or a similar structured drug. So we can see at the end the example that K et al. Refined a previously published PBPA model to include the CYP3A4 activity changes during the third trimester based on data from probe drug midazolam and used it to predict the exposure of nifedipine and indinavir in pregnancy. So this is another way. So the drug placental metabolism, the placenta is able to metabolize the drugs, and the human placenta is much less active organ in the biotransformation process than the liver. We know about these things, and some just a few points I would like to highlight, that what are the pathological effects of drugs on fetus and the newborn that we can come across if we are unaware about the adverse effects and we do randomly utilize drugs in the mother. The fetal emaciation, teratogenesis, carcinogenesis, there is a long list. Apart from this list also other effects we can expect. Fetal therapy, we do have advanced techniques in certain centers if at all it is required, like fetoscopy, laser, cystoscopy, cardiac valvuloplasty, open repair of spina bifida if surgical any intervention required. Fetal therapy, if we think it as a hope for the future, we know that the enzyme and other things that is deficient, like 21-hydroxylase deficiency, certain vitamin deficiency, and that vitamin deficiency can lead to fetal birth defects. So in those cases, direct instillation of those vitamins, certain essential vitamins, into the amniotic fluid by certain specific method can help to weigh out the come out the baby from the birth defect. I would like to, I'm towards the end of the session, that if we see that this is kind of simulation technique that has been used here, that this one is not working. So in the upper part is the caffeine, this is the middle part is the for metoprolol, and the lower part is the for the midazolam, that's for a bound and unbound drug, or predicted and unpredicted. So here we can see in the left part is the non-pregnant, and in the right part that is the pregnant, and that is for plasma protein bound and CYP enzyme functioning or not. So here we can see in the upper two panels the change of the area under the curve, change in the area under the curve, and the Cmax. If we see the table also along with this graph, we can see that there is a change in the Cmax also, but in the lower part, the midazolam, the predicted value and the normal value that you are getting, this almost similar, or that's touching. So if we are focusing on some regulatory issues on this PBPK, it's a viable alternative to generate the clinical data in special patient population, and regulatory agencies such as US FDA and the European medical agencies have accepted the use of PBPK modeling to facilitate the decision-making process for conducting clinical study in submission for IND and NDA. So with that, I would like to thank you and thank the organizers, especially team ACPICon.
Thank you, Dr. Sumalya. It is a wonderful presentation. And may I now request Dr. Handu sir to unmute yourself, and if you have any comment or anything to say, sir.